Welcome to our presentation on our case study, Peg Bundy. According to the case outline, Peg began experiencing localised right plantar forefoot pain after taking up walking 6 kilometres per day. Prior to this, she led a sedentary life. Her symptoms are exacerbated with long periods of weight bearing. Peggy's BMI is also slightly above the normal range, adding to the load on the foot. Upon observation, there is mild swelling on the dorsal aspect of the second MTPJ and clawing of the second digit. There is decreased first MTPJ dorsiflexion and pain on palpation of the second metatarsal head and proximal phalanx. There was noted increased mid-tarsal joint pronation during mid-stance and weight bearing through the lesser digits during propulsion. Based on these assessments and the evident foot discrepancies, Peg's symptoms are indicative of a plantar plate tear. The plantar plate is a fibrocartilaginous thickening of the metatarsophalangeal joint capsule that is firmly attached to the base of the proximal phalanx and loosely attached to the metatarsal head. The plantar plate acts as the major distal attachment of the plantar fascia and has attachments to the deep transverse metatarsal ligament and MTPJ collateral ligaments. It also serves as an insertion for both the lumbrical and interosseous tendons. Inferiorly, the plantar plate has a smooth grooved surface for the passage of the flexor tendons. The plantar plate serves to stabilize the MTPJs, assist in the windlass mechanism, resist hyperextension of the MTPJs, and absorb compressive loads. A plantar plate tear is typically described as a progressive, painful subluxation or dislocation of the proximal phalangeal base on the metatarsal head that occurs as a result of weakening of the periarticular structures that stabilize the MTPJs, specifically the plantar plate. Localized plantar forefoot pain is commonly caused by tears in the plantar plate. The subluxation process can be gradual or rapidly progressive. Plantar plate tears generally result from repetitive overload, abnormal forefoot loading patterns, excessive pronation, short first metatarsal or long second metatarsal. The tear usually arises from the base of the proximal phalanx. The second metatarsophalangeal joint is most commonly affected, as it is more often than not the longest metatarsal and has unopposed lumbricals and no plantar interosseous insertions. Going through the orthotic prescription flowchart, we firstly identified that the tissue under stress, as mentioned previously, is the plantar plate, specifically in the region of the second MTPJ. This was based on her presentation, musculoskeletal, and biomechanical findings. The pain is mechanical in origin, as she has begun walking in the last 4 months after living a sedentary lifestyle. Also, her symptoms have been present for 2 months. This, coupled with her weight bearing through the second to fifth MTPJs, would cause the plantar plate under the second MTPJ to be repetitively overloaded. Orthotic force should be applied to the midfoot, and custom-made orthoses should be used, as there are differences between both feet. Accommodation for reduced range of motion at the first MTPJ on the right foot is required. We do not want to apply much force to the midfoot, as her foot is relatively neutral, and we do not want to overload the lateral aspect of the foot, which is already weight-bearing through propulsion. Applying a mild force will hopefully be enough initially to support the arch, help the midfoot supinate through mid-stance and late mid-stance, and help redistribute pressure from under the second MTPJ. Any greater force could be likely to cause further issues and non-compliance issues for Peg. Before progressing, we will discuss costs involved and see if this may be an issue for her before we prescribe. As stated previously, we chose to prescribe Peg a custom orthosis based on biomechanical assessment and felt that this would better achieve the goals that we were after. A modified root device was selected as it is designed to correct the arch, support the mid to forefoot region, and designed to allow for first ray function. A concave wedge will provide a lower profile orthosis for Peg, as some of her footwear choices would not accommodate a traditional type. Peg scored +5 on the FPI, which places her in the neutral to slightly pronated range. We chose not to add correction for either foot, as we can assume she has a neutral foot based on this FPI, and we can see from the video that the calcaneal position is neutral throughout all phases of stance. At the moment, Peg is propelling through the 2nd to 5th toes, and that increases the pressure under the lesser MTPJs. The first ray accommodation will help to promote first ray function, allowing it to drop and help propulsion coming from the first MTPJ. Peg's joint range of motion test was only 45 degrees, half of what we would consider normal. Hopefully the accommodation will allow more movement at the first MTPJ. We would also include a second MTPJ cutout to help offload and reduce pain at the site. We selected a standard shell shape at 4 mm with the forefoot slightly wider to accommodate Peg's foot. Peg is increasing her walking and trying to lose weight. However, her current pain and discomfort when walking is inhibiting her from achieving her goals. A desirable material to use for Peg's orthoses would be polypropylene. Polypropylene is a firm yet flexible material that is available in a variety of thicknesses, ranging from 2 mm to 6 mm thick. We decided to use a thickness of 3.5 mm for Peg, as she needs flexibility in the orthosis for her exercise. However, she has a slightly high BMI, so choosing a thicker material that will not fully collapse under her body weight is suggested. This in turn will help Peg be able to tolerate the device and increase compliance when wearing it. A half heel stabilizer will help cradle the heel in the orthotic and keep it in a neutral position. Polypropylene would be better than EVA because it is more durable, and as Peg has a slightly high BMI, it won't compress or wear out prematurely. A standard cover would be used, finishing at the web space of the foot. This allows for more room at Peg's toes if she decides to wear the orthosis in her Mary Jane style shoes and still be able to have an extrinsic metatarsal dome added if needed. The materials used for the top cover would firstly include a cambrel base, which is used as a tough base for the orthosis that can deal with high impact and to make the orthosis more durable overall. On top of the cambrel will be a layer of 1.5 mm thick poron, which is purely used for patient comfort, as it is softer and will be shock absorbing for Peg when she is walking. Polypropylene can be hard under the foot. This will in turn help her to tolerate the device as well. Lastly, a LunaSoft top cover would be used as it is hard wearing and once again soft and shock absorbing, allowing for a more comfortable feel underfoot as well as absorbing properties which will help draw the moisture away from Peg's feet. It is imperative to reduce forces placed on the affected area by redistributing pressures, altering joint kinetics and impact forces acting on the affected area by the use of offloading with an orthosis. We have included 3 orthosis modifications that we would consider. The first is a metatarsal dome. This would be added to the orthosis shell extrinsically and will offload pressure by applying a spreading force to the metatarsal heads. This would reduce submetatarsal head pressure from the problem area and redistribute it more evenly throughout the forefoot. This is a relatively cheap modification and is easily fitted or modified in office. The second is a U'd cutout sub the second MTPJ. This modification will be made on the shell of the orthosis by footwork. With the decreased range of motion of 45 degrees dorsiflexion at the first MTPJ, it is possible PEG has a dysfunctional first ray and will contribute to the overloading of the second to fifth MTPJs. Restricting the ability of the second to hit the ground first during walking and redistributing the pressure evenly throughout the forefoot to avoid overloading during gait should provide relief for PEG. The third modification is a plantar pad with a U'd cutout sub the second MTPJ. Also added extrinsically, and this will also redistribute plantar pressures over a larger area. The U'd cutout will provide some relief to the overloaded second MTPJ, distributing the pressure more evenly throughout the forefoot. As discussed, plantar plate tears occur due to the repetitive overload from abnormal forefoot loading patterns and can be due to many different reasons. It is important to take a holistic approach when managing the patient and not just treat the pathology itself, but address the underlying etiology. The orthotic used in the conservative treatment of a plantar plate tear hypothetically aims to influence kinetics by altering forefoot plantar pressures. Hopefully the orthoses will keep PEG off the couch, help her return to her activity with comfort, and be able to continue to reach her goals. Thank you.